We're excited to present tonight's Stryker ENT webinar, When and How to Use Balloon Sinus Dilation, a case-based discussion with Doctors Ayesha Khalid, Nipun Chhabra, and Paul Lenkowski.
Perfect. My name is Ayesha Khalid. I am an ear, nose, and throat physician practicing at the Cambridge Health Alliance in Cambridge, Massachusetts. And I am very excited to be co-presenting with my colleagues.
My name is Nipun Chhabra. I'm a fellowship trained rhinologist, currently in private practice in Leesburg, Virginia. Prior to that, spent many years in academic practice in Cleveland, Ohio, and thank you all for joining us and very excited to be here tonight.
I am Paul Lenkowski, also from Virginia, Roanoke Valley ENT and Allergy, and I'm a private practice ENT and sinus surgeon. And I've been doing these procedures with the balloon for about 10 years or so. And I'm grateful to be here. I'm looking forward to a great talk tonight. So thank you all for having me.
Thank you so much. Thank you, Allison, for the next slide. So balloon sinus dilation. So we thought we would take you through a journey to really talk about where and how this might fit in your practice, whether you're a rhinologist or a generalist otolaryngologist. We want you to think about it as a stepwise approach. And you can see that on the left, we used to have a few tools and steps with our surgeries, and now we have many more, as we like to think of it, rungs in the ladder. And we'll show you through both an agenda that will cover the objectives of balloon sinus dilation, but also hopefully leave you with some pearls of different ways and approaches through our cases. Next slide. So our objectives today are threefold. First, we're going to discuss the history of balloon sinus dilation in otolaryngology, or as I like to say, otorhinolaryngology. We will explore when and how balloon sinus dilation may be incorporated in the management of chronic rhinosinusitis. And finally, we'll highlight for you as best we can current trends and future directions for the use of balloon sinus dilation. Next slide. Often you will hear us say as presenters, we want to be doing the right procedure for the right disease. And in fact, in preparing for this, we also want to approach it as the right procedure for the right patient. So bear that in mind as we show you these two scans. The image on the left, the coronal CT, looks very different than the image on the right, another coronal CT. Different disease processes are happening. Is the treatment going to be different? What are your goals of surgery for these patients? And finally, bearing in mind, if we're treating the patient and not the scan that we see, what are their symptoms before and after? And we'll try to address that. Next slide. With the evolution of this concept of the right procedure for the right disease, imagine that, as we know, with rhinosinusitis, acute then chronic, all the way over to the right, we can see that the severe forms of inflammation can often have nasal polyposis. So we're thinking about a paradigm of infection and obstruction all the way to severe inflammation. And you can see along the bottom that this has really evolved in practice for many people. When balloon sinus dilation came, it could be thought of as less invasive. And the question becomes, where does it fall in this paradigm of disease? So we have balloon sinus dilation, we have functional endoscopic sinus surgery, which, as we know in discussions at our meetings, can include what we refer to as small hole versus large hole. We talk about the milieu and the microenvironment of bacteria and drainage. But now there's a concept that we want you to bear in mind for this presentation, which is the hybrid FES. And for the purposes of this talk tonight, hybrid will refer to if one is doing both traditional instrumentation for some of the sinus part and nasal part of the surgery in combination with using a balloon sinus dilation in one or many of the sinuses. And we'll get more into that in the cases. Next slide. So with the evolution of balloons in otolaryngology, you can see that, for example, when I was in training and balloon sinus dilation was introduced, we really had much more equipment intensive and risk intensive. We had to do fluoro-guided transantral approaches. It looked very different than it does today. Then that was followed with multiple types and forms of transnasal devices, things that could go through your nostril and can also start addressing multiple sinuses effectively. Then we saw the, introduction and enabling of image-guided sinus surgery and allowing image-guided sinus surgery to then also be brought to the office setting. So we can talk about that as well. And finally, now we're in a debate and a discussion which is very healthy, where we really want to think about the role and indications. When is balloon sinus dilation indicated? When is traditional surgery indicated? When is a hybrid FES indicated? And for many of us, as we all know, treating patients, what do we do with the eustachian tube? And is there a role for really clearly thinking preoperatively around eustachian tube dilation? Next slide. So with surgical interventions and patient selection, I'm presenting something that really is an overview, and we're going to show you a few cases to let you know what our approaches are. On the left, you can see that balloon sinus dilation alone can address the maxillary, the frontal, and the sphenoid sinuses in both sites of office, both the office and the operating room. We can see in the middle what we know as traditional functional endoscopic sinus surgery, where we can do a frontal sinusotomy, a maxillary enterostomy, a partial or a total ethmoidectomy, a sphenoidotomy. And finally, the real exciting part, for me at least, comes with the area on the right. When and how is the role of the hybrid FAS? Where in my practice, often I will be doing maxillary enterostomy, a total ethmoidectomy with a frontal dilation for the right procedure for the right patient with the right disease. Next slide. So what are the advantages of balloon sinus dilation? Because I imagine that not everyone is familiar or has used it extensively in their practice. Well, from what we tell patients, balloon sinus dilation can really relieve obstruction in the right patient, the right chosen patient that's appropriate. It's convenient. It's generally well tolerated. The recovery time can be much quicker and easier. There are rarely the risks of complication compared to the larger functional endoscopic procedures. There's a low revision rate. You may require less postoperative debridements and or crusting noted by the patient. And depending on your practice setting, you may be able to get remuneration whether you're in the office or the operating room, but most importantly, the patient just may recover a lot quicker. Next slide. What are the limitations? So every procedure has advantages and disadvantages. And clearly, as you'll see from all of us as panelists, balloon sinus dilation is not suitable for all patients. And we want you to leave here today realizing that standalone balloon sinus dilation is a very different procedure for a very different patient than functional endoscopic sinus surgery. It is not a procedure intended to remove tissue such as polyps or specimens that you're worried about in a tumor setting. It does not directly address the ethmoid sinus, which we know can be the heart of the sinus obstruction in many patients. And it may be challenging in complex anatomic situation, especially given the superior aspect of the septum, for example. Next slide. We put this slide up not to have you read through all of the studies, but to really show 2 points. Balloons can be effective tools demonstrated by several peer-reviewed publications. But the second thing to note on this slide is the timeline. So we are really looking at 2009 all the way till this ends at 2019. Data continues to come out, but that is a very long span of time over several years with peer-reviewed publications. And at the end, we'll provide a reference list if anyone is interested in taking a look. So as we discuss now, sort of the framework that we want you to think about is that there will be some patients that require functional endoscopic sinus surgery, particularly given either their CT scan, their disease burden, or what their inflammation is like. And yet there may also be candidates that can do very well with balloon sinus dilation and even limited balloon sinus dilation, depending on where and how they're experiencing problems. But again, to highlight that interesting patient that may have some of their sinus and nasal surgery addressed with traditional instrumentation, and others, in my practice, often either the frontal or the sphenoid, addressed with a balloon sinus dilation. So we'll really try to tease that apart for you. Next slide. So there's many decisions. We want you to think about these question areas as we go through the presentation. What should be the extent of the FES as you think about your patient? A hot topic is, can balloons and polyps mix? That is an interesting question to be asked, and we will answer it with very different points of view. What are anticipated problem spots as you're considering, particularly in the hybrid situation? And finally, what about the eustachian tube? Sometimes, in fact, often forgotten, that can lead to symptoms for the patient. Next slide. And with that, I go ahead and hand it off to my colleagues to present the case studies.
Okay, thank you. So in all of these cases, we're going to be kind of asking some questions to the audience as a poll, but we'll start off with just the first case. This was an 80-year-old gentleman that was referred to me. He had had a prior history of a balloon sinuplasty and wasn't very symptomatic, primarily just had some nasal congestion and maybe a little bit of right-sided periodic facial pressure around the maxillary region. And so we can see here that the coronal CTs demonstrate what looks like some kind of polypoid type mass that's unilateral on the right side of the sinuses and the maxillary sinus, maybe a little bit of a lumpy, bumpy appearance. And there's been at least a partial antrostomy or some kind of dilation that was performed, but it looks like maybe even a partial antrostomy where some tissue was removed. On the axial CT, we see a little bit of hyperostosis along the borders of the maxillary sinus, more posteriorly and medially. And not much other disease in the ethmoids and not great views of the frontal, but those were his primary complaints. And I guess we can go ahead to the next slide. So here's the poll that we'll be kind of going through for each of these cases tonight. And in all of these cases, we'll ask the audience how you would intervene. So, these are the different options: standalone balloon sinus dilation, a traditional FES or functional endoscopic sinus surgery, a hybrid FES, which we discussed a little bit, could be defined as whether or not you're using the balloon alongside traditional instrumentation, or you may be using the balloon alongside other parts of the sinus surgery. Maybe use the balloon for a maxillary sinus or a frontal, but you're also doing some ethmoid work. You may be removing a concha bullosa. Sometimes you may use the balloon as just an access instrument, and then you may go ahead and remove additional tissue as well. So those are the different definitions of a hybrid FES whenever it's used alongside or in addition to your traditional instrumentation. And then other, that could be anything from eustachian tube dilation to conservative measures to nothing to medications. So yeah, we'll go ahead and have the audience put their thoughts in for this case. Looks like most people are leaning towards a functional endoscopic sinus surgery or a FES, but also a hybrid. And I think that's a really intriguing poll results there that we saw for this case, because both hybrid and FES were kind of the leading runners here. And I think that, in this case, what we could see, if we look kind of closely on the axial image, there's a little bit of hyperostosis of the posterior medial wall. So I didn't give you all the details for the case intentionally, but this patient actually, at the initial time of their balloon sinuplasty, before they were referred to me, had a biopsy performed of the kind of superior aspect of that tissue, and it came back as inverted papilloma. So this was an endoscopic sinus surgery, or in my case, I went ahead and performed an endoscopic medial maxillectomy with removal of the inverted papilloma directed at the attachment site, which was around that hyperostotic bone, and that area was drilled and cauterized. So in this case, I just did the FES or FES technique thereof for tumor removal. Next slide. Okay, we'll go on to case 2. Here's a 62-year-old gentleman with a history of prior sinus surgery. They had had a pretty comprehensive FES performed, and really primary symptoms only of nasal congestion and just unilateral right-sided frontal headaches and pressure. And we can see here on the coronal CT, septum looks midline, and unilateral pacification of the right frontal sinus, retained auger cell there. And we'll go ahead and see how everyone would intervene. Great, so here in this case, standalone balloon sinus dilation was the winner. So in this case, standalone balloon sinus dilation is what I chose to perform, really directed just at the patient's right frontal sinus, because that was the only sinus that was opacified. That was the only sinus the patient really had any kind of complaints for. So this is really an example of where we spoke earlier about kind of the right tool for the right disease for the right type of patient. Next slide. And here's an intra-procedure view. This is the right frontal sinus after it has been dilated. I went ahead and used a suction just to widen that a little bit, followed by balloon dilation, or dilation followed by suctioning. And you can see that there was good release of this really thick inspissated mucus and secretions, which had been there for quite some time. And that patient went on to do really, really well with complete resolution of their frontal headaches and pressure symptoms.
I'm going to present the next few cases. I love cases like these. So this is a 53-year-old lady that came to my clinic. She, typical congestion, drainage, facial pressure, no hyposmia, present for a long time. And, she's had lots of medical therapy, saline rinses, Flonase, allergy testing, all these things. Lots and lots and lots and lots and lots of antibiotics. In my clinic, we always get a SNOT 22. Her score was 50, which is right on the threshold for what's considered significant. So this lady clearly has sinus disease. I like this one because it's somewhat challenging anatomy, gigantic inferior turbinates. She has elements of, atelectatic, if not silent sinus syndrome on the right-hand side. It has disease on the left-hand side, left maxillary sinus, left frontal sinus, left ethmoid sinus. And so I'd like to see what our audience thinks about this case, how they'd approach it. So let's go to our poll here. I did do a hybrid FES. So obviously I needed to get access to her sinuses. And I don't really fault anybody that would say traditional FES would be the way to go, particularly with that atelectatic maxillary sinus. You might think, how the heck can you open up that sinus with any tool but a cutting tool? Okay. Well, I will tell you that I'm not a rhinologist. And so, I've learned this through, years of experience is that, these procedures had scared me for years. And they scared me because, I was taking a rigid instrument and sticking in an area where it's hard to see. Use image guidance, but still it's hard to see. It's hard to get access. So we do need some dissection for access. So it makes it a hybrid case. How do we approach the sinus? But think about how do I approach a sinus? My goal is for this to be effective, right? But more importantly, safe. We're near the orbit. We don't want to cause damage. We don't want to get into the orbit or cause orbital dehiscence or orbital fat, and then use a microrepeater to cause, an injury. That's the thing. Is the first thing we do is do no harm, right? So that's why I like using this balloon device, because the Express device in particular, compared to other devices, it's basically like a rigid seeker. But what's nice about it for me is that it's malleable, so I can bend this to whichever way I want to get into that sinus. So we typically use for the maxillary sinus a 120 or 135. And then the length of the distal portion of the bend is set up by the bending tool. But you can modify that. So you can do the traditional bend and then you can do additional bend to get into difficult sinuses, which indeed I did in this case. So I used my bending tool to bend to 120. Then I bent it a bit more to get more lateral. And I had complete visualization, complete confidence. You can use a light wire, or I also like the fact that it's image guided. In this case, it was image guided. And so then I dilated it, opened the maxillary sinus. I was able to medialize the uncinate, and I was able to take down the uncinate, which I did in this case. And on the right-hand side, after I took down the uncinate, I could see my balloon ostium. I actually widened that as much as I could, which was not much more than the balloon did, but I could see, and then I fleshed out that sinus. And I felt particularly comfortable in this case because I knew everything I was using was safe and I could see everything I was doing. I could feel it, everything I was doing. And that's why I like the Express device as a tool for cases like this. On the contralateral side, it was traditional dilation. You can see that that's a little bit more normal. And I dilated the left frontal sinus and I debrided the ethmoid bulla. There's this phenomenon that I've seen often, which isn't described. And if you look at the coronal image down on the bottom left, you can see sort of that opacified posterior bullous cell. And so like the bulla can sometimes overhang the uncinate in a way that makes it actually really hard to access the infundibulum. And so in that case, what do? Well, if all you have is a balloon, it's actually can be a struggle. And so you might feel, well, and this is a case where I have to do a traditional antrostomy. Really, if you just take down the bulla, now you have access with your balloon to balloon dilation. And I like that for stepwise therapy because like in that first case that Dr. Chhabra showed, no one will fault you for having to go back in if you find something you didn't expect. But you do sort of fault yourself and hold yourself accountable when you cause an injury you could have avoided. And that's why I like using these hybrid techniques, is because you avoid a lot of the potential morbidities associated with more extensive dissection. And because it's a stepwise approach, you can tell your patient, this is the first step, right? Sinus disease, particularly chronic sinus disease, is a chronic condition. There might be other procedures. Let's do this one step at a time. Let's start with the symptomatic and affected sinuses and go from there. Because our goal is to make you better And part of our goal is to not harm you. So this is why a case like this, I think, is perfect for a hybrid case. Let's go on to our next case. All right, so this is a gentleman, elderly, 74-year-old, no, not elderly, we call him middle-aged nowadays. Same deal, except he had hyposmia, facial pressure, congestion, for 3 months. And, he's been on lots of antibiotics, lots of steroid rinses. He was on metazone rinses. He's had allergy testing. He's been on allergy shots. And this is a really interesting case to me because I look at this scan and I'm like, well, there's some complex anatomy there. He has concha bullosa on the left-hand side, a narrow infundibulum. This scan doesn't show all the parts of it, but it just sort of shows it. He has mild sinus disease, but he complains of facial pressure on his forehead and his cheeks. So we'll call that, important. And he has relatively complex frontal anatomy, particularly if you look at that sagittal view. There's a lot of cells there that you could dissect through to get there. And I think in the past versus the current, how would we approach this? So when our only tool was to do a pretty, significant dissection, does that necessity for significant dissection change your threshold for intervention? This is a question that often plagues, ENT surgeons all the time. Does a tool that's safer, lower your threshold for intervention? Or do you just let people take more and more medical therapies, knowing that it doesn't really treat the root cause, which in this case is anatomic? So let's actually do the poll on this one and see how people would approach this. So the majority of people chose hybrid FES, which is what I chose. And, we define hybrid FES as like traditional combined with balloon. And so in this gentleman, we can go to the next slide. I took down that concha and he sort of has a pneumatized lamella of his middle turbinate, took that down. You can see that ethmoid cell was in the way, took that down. And then once we took down the ethmoids and the concha, we had, complete access to his maxillary sinuses, which we dilated. And the disease in his maxillary sinuses was not severe, but his symptoms were present there. And then once we opened up the anterior ethmoid cells, we had much more easy access to his frontal recess, and we dilated his frontal recess. And so what's cool about this gentleman is that, there was some recidivism in this gentleman, but it wasn't in his sinuses. So he comes back, he's like, you know what? I don't have any more pressure. And in fact, his sense of smell did improve because we did ventilate his sinuses and his nasal airway, so he could breathe better. But unfortunately, it revealed the fact that now that he could breathe through his nose, he had nasal valve collapse on the left. Well, guess what? He got Latera a few months later and was like super happy. So now he can breathe really well. He has no symptoms. And he did this through a hybrid FES. And I would say that probably 15, 20 years ago, this is a patient that we probably would not operate on, or at least not too extensively. Might do a maxillary antrostomy and an anterior ethmoidectomy and a concha reduction because of potential, fear for damage to adjacent structures. And, it's a much easier conversation to have with our patients now. And we say, okay, let's do a stepwise approach. These are your symptoms. We're going to treat your symptomatic and your affected sinuses in the most effective way possible, but we're going to do it in the way that creates the least amount of side effects for you. And so for me, that's where I find the Express device to be most helpful, because we can use that device to access sinuses we wouldn't otherwise maybe access, or wouldn't feel like they were threshold enough to take them to that level of therapy. But you can clearly see this person has frontal sinus disease. And I will tell you genuinely that his frontal sinus pressure went away after his procedure, after he recovered. So this is a great example, again, of where, we have this new step, we'll call it hybrid FES, between medical therapy alone and extensive dissection, another step along the way. Stepwise therapy is like, all the rage now in pharmaceutical companies, but this is actually true in surgery as well, which makes this really exciting for me. And so I was so, happy to be able to help this gentleman because, again, 20, 15 years ago, we'd be afraid, I think, to do too much treatment to his frontal sinuses. And now it's like, oh yeah, easy peasy.
All right, awesome. Thank you. So my cases are up next, and I have a tough act to follow with Dr. Lenkowski and Dr. Chhabra. I will say, Dr. Lenkowski raised a really good point. Goal number one is always to keep the patient safe. And goal number two is to do, whatever stepwise therapy to relieve their symptoms. And then personally, for me, having had a background in this, goal number three will really tie into what we've been talking about, which is the restoration of mucociliary clearance. So just bearing in mind that, at least for my patients and my approach in my practice, the goal is what is the surgery that I can do, and perhaps the least surgery I can do to get the patient feeling better and to have the sinuses ventilate themselves, because the goal of endoscopic sinus surgery, balloon or otherwise, is really to allow the sinuses to take care of themselves, as I described to patients. So let's talk about this patient. And this is a 43-year-old male, long known to me. In fact, the background on this patient is I had years ago done a tonsillectomy and uvula removal, like a UP3, because he has pretty bad sleep apnea. And he's been treating that with a CPAP and had long complained of nasal obstruction, but I wanted him to sort of start getting ahead of that disease. And sure enough, he comes back and says, I've had the 20 years of nasal congestion, but on top of it, in the last several years, I have had many courses of antibiotics, many courses of prednisone. And he confesses that the reason I didn't know is because it's very easy for him to get prednisone and antibiotics at the closest urgent clinic. So that was the first telling sign to me. He was very specific. So imagine that this patient has mid-ethmoid pressure, facial pain, and I put positive allergy test, but what that really means is this is a patient with copious amounts of mucus drainage out the front of his nose as well as the back of his throat. And that can often for us be a confounder as treating otolaryngologists, because how much of it is the sinonasal disease that can be anatomically repaired and how much of it is the lining and inflammation. So now let's move to the CT scan done a few weeks post his last treatment with antibiotics and prednisone. And sure enough, you can see on the left-hand side and a little bit, posterior view coronal wise on the right-hand side, but at least on the left-hand side, pretty significant obstruction on the left, paying attention not only to the maxillary sinus, which is near completely opacified, if not completely opacified, but also note that while his frontal sinuses are small, and we can't fit all the views here, you can definitely see that the middle turbinate and that anterior ethmoid region is really obstructed with potentially, is it polyp, is it scar, is it infection? On the right-hand side, his disease is a little bit less, but again, you do see some patchy ethmoid opacification on the left-hand picture and clear evidence of this chronic inflammation in the right maxillary sinus. But when you go to the left, when you go to the photo on the right, the CT scan shows you that that continues. So remembering that this patient has allergic inflammation present, remembering that he's been on therapy, and remembering that his primary complaint is mid-ethmoid pressure with some issues with his maxillary sinuses, let's go to the next slide and to our poll. What would you do for this patient? All right, so interesting results. Not altogether surprising. I think for the 29% of respondents that said traditional FES, that makes a lot of sense given the fact that there is significant disease on that CAT scan. And the hybrid FES, nearly 3/4 of the respondents stating that they would do a hybrid procedure. No one would do something else, and then no one would do standalone balloon sinus dilation. So let's go to the next slide. And so here is what is really interesting. So this patient, of course, like Dr. Chhabra, I left out some details. He's got a history of heart disease. He's somebody that I want to get in and out as quickly as possible. And I now have him on immunotherapy. I had a long conversation with him. We can go ahead and do a traditional procedure and or a hybrid, or we can try the balloon. And if it takes care of your symptoms, I should state that what I did in this patient was not only a standalone balloon procedure, but I also did an inferior turbinate reduction, which to be fair is a nasal procedure. And next slide, I believe we have a video on this patient. And you can see in the video, I generally treat patients with some preoperative antibiotics and steroids. In this case, I did that as well. And I think many people would not be surprised that we're on the left-hand side and we're getting into the left frontal sinus. Lo and behold, that stuff we saw on the CT scan is polyps forming. You can see the mucopus, which I thought we'd all get excited about, coming out of the frontal sinus. And some would argue that If I create space and there's some ventilation and he is now able to get some topical therapies in, let's see what happens with that polypoid inflammation, particularly with the immunotherapy. So before I leave this case, I want to go back to what Dr. Lenkowski said, which is, for me, this is a step therapy in the sense that I can easily and readily take him to the operating room and do a full fast. But I also know that one of his goals is a very fast recovery, very fast back time to work. And he's a patient known to me with good compliance. And I think that part is really important. But in an earlier slide, we said, do polyps and balloons mix? And sometimes for me, they do. So I included this just for a little bit of exciting conversation for us later, obviously. Okay, so our next case, next slide. So this case, I wanted to include a lovely woman, 81 years of age. And I think that's important because I think someone who is as sprightly as her, both of her parents and the majority of her family are physicians or in healthcare. She's very well versed, but she has often gone in and complained for, she said, 8 years, if not 10 years, that while she has a history of hearing loss that is documented over time and uses hearing aids, she has had both allergic rhinitis symptoms as well as pretty severe and pretty distinct description that her eardrum or her ears pop open and close, and her hearing gets much worse even with the hearing aids in place. So after trying some nasal therapies, some sprays, really questioning her, this patient comes in and says, Doc, I'm not able to hear well, and I feel like there's something in my neck or in my ears that isn't working. And she's really failed medical management. So I guess let's put up a poll. The breakdown is really interesting for a point of view of discussion, in that 62% agreed that there could be a role for balloon dilation in this patient, particularly of the eustachian tubes. And 35%, I'll take it to mean, said either I would do no balloon, or I would consider tubes, or I would just consider rolling down the hall to my otologist and seeing if they could see that patient instead. So in this case, this patient was very willing. The topical anesthesia is quite simple if one is doing procedures in my practice, but it doesn't have to be. It's in the office. And you can see that she underwent a eustachian tube dilation without any difficulty. I tried very much to keep expectations low for this patient and say, listen, this may help you, this may not. We may be just looking at that's the state of affairs. She did great. She took an Uber because she's, not allowed to drive around in Boston given her eyesight. And she said for the first time in 8 years, she could understand the Uber driver rather than try to read the lips in the mirror. So I will admit this, and it's open to discussion with my colleagues, this is a sort of an extreme presentation of adapting eustachian tube dilation, but I thought it was very interesting because both given her age, given her history of some hearing loss with hearing aids, and given her symptoms, she had actually seen multiple otolaryngologists and been offered no therapy and told that's just how she has to live. So that is her case. Next slide. So key takeaways, and then we'll go to questions, but we just wanted to present that balloon sinus dilation offers advantages in appropriately selected patients, whether it's in the office or the operating room, and we're happy to chat about that. We know that there's limitations to balloon sinus dilation, and it's a tool like any of the other tools. I will emphasize the point that Dr. Lenkowski made earlier, which is I also like the Express device because it feels to me like a seeker, and particularly either like a frontal seeker or a Lusk probe. It's quite malleable and I can really adapt it to the different takeaways of the maxillary sinus. And then the indications and the usage for balloon sinus dilation, and including for eustachian tube, as we saw, continue to evolve and in some ways maybe expand to the recalcitrant patients that are a little bit more difficult to solve.
Great discussion to our presenters. As we flip through our next few slides, I'd like to remind the audience to please submit your questions via the Q&A icon at the bottom of your Zoom screen. And we'll take a moment to answer them.
First question. Dr. Chhabra, can you talk a little bit more about why you choose to use Express and how has it helped you in complex cases?
Sure, and that's a wonderful question. I think that when I look at my practice and kind of how Express has come to be part of what I use in sinus cases, it was sort of an evolution, right? I mean, as a rhinologist, we weren't trained on these devices. We were trained to be in the operating room using traditional instrumentation, using maximal large sinusotomies. But I began by using the Express device in the operating room, and from there, I found it to be very much, I'll echo what Dr. Khalid, Dr. Lenkowski said, it really felt like to me, traditional instrumentation that I was already used to using. The ergonomics of the device, much like a seeker, much like a curette, much like a frontal sinus seeker, the ability to be able to use those kinds of things and then just take that irrespective of where I was doing the procedure, it was really a natural transition and progression for me into using the Express device. I also really like the lighted fiber. I like the obviously degrees of excursion that we can use to be able to make sure that we're safe, that we're confident, but also the fact that the device is a very low profile and you're able to fit into narrow spaces, especially when it comes to complex cases. So if you have a complex frontal case where I found that sometimes I'll just use the device to help me get into supraorbital cells or supraaugular cells, or even sometimes interfrontal cells. And then I can go ahead and use my traditional instrumentation if I need to widen that sinusotomy. But the degree of efficiency, the fact that I can get lesser blood loss, and it just speeds up my personal operative time is a huge advantage. So especially for the more complex cases, I found it to be a huge asset in my practice.
Great, thank you. Dr. Lenkowski, there was a question that came through in one of your earlier cases. One of the attendees was asking how and where did you treat that concha bullosa for that case you were talking about? Was it in the office, or can you kind of talk through how you and where you treated that?
Sure. Yeah, that was indeed in the office, and I did reduce the concha. In that case, just traditional, make an incision, resect the lateral aspect with microreader, and that gave me the access I needed. Use that same microreader to take down the bulla, and that gave me access to the infundibulum to then do the balloon dilation of both the frontal and maxillary sinus. And that's just sort of, again, to reiterate what my colleagues have said, is just about the tool. The tool is basically the seeker, right? It's the seeker, but it's a seeker that can do a job. So you can get access to the infundibulum, to the maxillary ostium, and then while that tool is in place, then you can actually treat the sinus at the same time. And that's why I like it, typically for efficiency and for safety. So in cases where you have an awake patient or a patient that you're worried about their overall medical condition, you want to be efficient. You don't want to have to switch instruments. And I'm sure my colleagues have found that sometimes, like, you use a frontal seeker and you're in the frontal sinus and you want to hold it in there, and then you want to take it out and then do your dissection. But then you take it out and just blood comes down. When you have a balloon up there, or the Express device with the balloon on it, basically you bend it to access the frontal sinus, you get in the frontal sinus and treat the frontal sinus. When you have a tool that can access and treat a sinus all in one step, it just makes sense to have that available. Obviously, I'm a big fan.
Thank you. This next question, I feel like it would be great for all of you guys to answer, but Dr. Khalid, I would love to start with you. So the question is, how do you counsel patients on options of in-office versus best in the OR or the ASC, and how do you counsel on efficiency and other pros and cons of that?
Yeah, so that's an excellent question. I have a very typical conversation with the patient. It's very similar every time, and it starts with the following. What are you feeling and what do you think needs to be done? Are you at the threshold where something you feel needs to be done? Is that why you're here? A patient can have massive sinusitis on their CAT scan, like I showed in the introduction, and may say, I'm not ready to have any procedure done. And that's absolutely fine. But if they come and they say, I want to have this addressed, I usually look at it and my thought process is as follows. If you have limited sinuses that are involved and you are relaying to me as a patient that your time to recovery needs to be very quick, either you're a consultant, a healthcare worker, you need to get back to work, I can usually address, for example, isolated frontal and maxillary sinus disease with not a lot of posterior disease or polyposis in the office. And I can really open up the sinuses, as well as in my practice, do a turbinate reduction utilizing a shaver, and I can give you a better nasal airway. If we need to, we can even do something for your nasal valve. So we can end up in a place where we've treated either recurrent acute or chronic maxillary and frontal sinusitis in the office pretty readily, and or taking care of your nasal passages with the turbinates. So that's a long way of saying, I usually look to see if you're a candidate for an in-office procedure. And I almost, over the last 10, 15 years, have started to need to check the boxes for me to give you general anesthesia and take you to the operating room. In some of the cases we presented, like Dr. Chhabra's case, where there was a, one sinus with packed in and we don't know what that is, that, for example, would be a case, I don't know what I'm dealing with. I'll go to the operating room and I may still start with doing a hybrid procedure in the operating room, but I need potentially tools to address bleeding, and or I need tools to address pathology. I actually, very differently maybe than others, had first started 7 or 8 years ago doing balloon dilation in the office. That was just the nature of the way the practice went. But I now do balloon dilation and hybrid FES in the operating room and do quite a bit of balloon sinus dilation in the office. And I want to make one last point. It is very important for one that wants to use balloon sinus dilation as a tool to use it often enough on easier cases, whether you decide to do that in the office or the operating room, rather than to start and pick that perfect case, maybe with that complicated atelectatic sinus that Dr. Lenkowski showed, and then be trying to learn how to be using the balloon. So I think getting facile with it as a tool will make you more comfortable.
The concept of the balloon as a tool and the balloon as a procedure, right? The balloon is a tool sometimes when you're doing a more complicated procedure, and sometimes the balloon is the procedure. When the balloon is a tool, it's a hybrid. When the balloon is the procedure, it's a balloon sinus dilation. But I like that distinction in kind of the spectrum of disease, because really severe disease, you might use it only as a tool to access something that was difficult to access. And in someone with recurrent acute rhinosinusitis, the balloon is the procedure as well. And it's amenable to both. But I like how we all see it now as a tool because we use it all the time. But a lot of people, at least in the past, have thought of it as a procedure. And so as a procedure, it has limitations. But as a tool, it can do a lot more than just a procedure. And I like the way you talked about that. So that's a really good point. So for our listeners, there's balloon sinus dilation, which is a procedure with a specific CPT code. But a balloon as a tool is a very powerful tool that you can use sort of independent of what people call it, right? And so that's something that we, again, that's why I feel like people should use it. And like you said, when you're using it for the first few times, use it as a procedure so you're familiar with it, you're facile. But then once you've used it, you can actually use it in so many ways you didn't think in the past. And so in a way, and like you said, I feel like it does, when you're facile with it, it actually does make you a more effective proceduralist or surgeon, if you will. So.
Yeah, and I'll just echo both what Dr. Lenkowski and Dr. Khalid said. I will say that there's pretty good data out there, as everyone's alluded to, that we're treating the patients and not treating the CT scan, right? So sometimes scans are normal, and we've seen those patients during acute flares. We've documented those acute flares. We've seen that they've had 4+ sinus infections a year. Patients are asking to have something done, and they're really looking for more treatment options. And I think seeing those patients, capturing them at the right time is helpful. And then we're giving them different ideas on the step ladder. It's something less invasive to something more invasive. When it comes down to deciding about whether I'm going to do something personally in the office versus the operating room, I do like to ask patients about their anxiety. How do they do at the dentist, for example? Things like that I find to be quite helpful, because that will also give me a good gauge as to whether or not the patient may be better suited for one side of service versus a different side of service. But also, having been in academic practice for many years, of course, seeing some of the more complex tertiary cases, some of those, are done in the operating room if they're revision or if the AERD cases. But even then, still using the balloon as a tool has been instrumental in my practice. I really feel like even for those complex cases, especially for some of the more complex frontal anatomy or even a couple of revision cases, having that tool has been very helpful and has been an evolution. But at the end of the day, I think that we have these instruments to offer patients. We have this armamentarium, and it really should be part of our practice across the board.
Great discussion and conversation tonight. I know we are past the hour and there are some questions we weren't able to get to tonight. So please reach out to your local reps. They can get you in contact with any of the presenters tonight to answer these questions and go into them in more depth. But thank you so much to all three of you. I'm going to turn it back over to Allison to close us out.
Yes, I want to echo Katie's sentiments and thank our presenters, Dr. Chhabra, Dr. Khalid, Dr. Lenkowski, for lending your expertise this evening, and our audience for your excellent engagement. As Katie said, be sure to stay in touch with your local Stryker ENT representative or visit our website to stay in the loop of medical education opportunities, like a peer-to-peer call in which she mentioned if you'd like to ask a presenter more questions surrounding clinical utilization of balloon sinus dilation, or even our advanced sinonasal course in which we expand upon tonight's theme alongside some cadaveric training. Thank you all again and have a great evening.